Hello and welcome to Health Professional Radio. Thank you for joining us here today. I'm your host, Neal Howard. In studio with me is returning guest, Dr. Tina Mahajan. She's the Division Chief of Female Pelvic Medicine and Reconstructive Surgery at University Hospitals in Cleveland, Ohio. And she's here today to talk with us about the field of urogynecology. Welcome to the program, Doctor.
Thank you for having me, Neal.
Thank you. Well, the field of urogynecology, I thought that gynecology kind of encompassed everything down there. Talk about how you became a specialist in the field of urogynecology.
Well, it all started actually in college. I decided I wanted to be a gynecologist in college because I was very interested in women's issues, and I came from a medical family. And so I'd grown up in that environment. And then when I got to medical school, went to OBGYN, I was really more interested in the moms than the babies and interested in gynecologic surgery, and I loved the operating room. And then when I got to residency, still continued to be interested in gynecologic surgery. But even in medical school, I'd really enjoyed plastic surgery, but didn't want to be a plastic surgeon, didn't want to do breast augmentations my whole life. So I enjoyed urology and basically decided as a resident, or actually not even as a resident, as a medical student, that I wanted to be what we used to call a urogynecologist, but now we call a female pelvic medicine and reconstructive surgery. And I did 4 years of residency in OBGYN and then 3 years of training and subspecialty in urologic gynecology, and did a dual fellowship in urology and urogynecology, and then started our division right out of fellowship. So it was a long path, but basically I do gynecology meets urology meets plastic surgery. I always tell patients that I'll make everything look like they're 20 again, and they can have as many kids as they want or do whatever they like, and we'll fix it all and make it all look perfect again.
You're involved in the overall health of the female reproductive system in all aspects. You mentioned plastic surgery. Is that what you do normally, or are there times when you're called upon to perform a hysterectomy or something else?
So I do often do hysterectomies, but most of my work has to do with leaking with coughing, sneezing, bearing down. Nobody should have to wear a pad or a diaper, or not be able to exercise or go for a walk because they're worried they'll leak urine, or laugh very hard. We often treat that with exercises, sometimes and often surgery. I also do a lot of dealing with non-medical incontinence, meaning the bladder wants to empty even when you're not at the bathroom yet or feeling an urge to go you can't control. And we treat that with being smarter about our fluid intake choices, conservative treatments, sometimes medications, and rarely more invasive things. And then one of the biggest things I do is prolapse, when you feel a bulge down there that shouldn't be there. People have always talked about a fallen bladder or a fallen rectum or a fallen uterus. We make things as they should be. Sometimes that involves a hysterectomy, but often it means restoring the supports that over time start to weaken and not hold up against gravity. I always tell my patients that gravity is not our friend. And just like we start to droop in our breasts, we start to droop down there, and we'll make everything resist gravity again, make it look good again, and feel good. That's the most important thing.
You know, when you're talking about prolapse issues, is that something that's more prevalent in older people, or can that happen for a variety of reasons, no matter what the age? And when that does happen, does age play a huge factor in how it's addressed?
It definitely can happen. It's more common as we age, but I have patients in my 30s who have uteruses that are almost all the way outside and falling out. But it tends to be related to multiple issues. It's genetics is the biggest thing. So if your mom had a bulge, you're more likely to have a bulge. Or your sister has a bulge down there, or leaks when she coughs and sneezes. It also has to do with having children. The more children you have, the more risk you are. If you do heavy weightlifting in your daily life, I once had a patient who was a welder, and she lifted 50-pound metal sheets, and she developed a prolapse or a bulge just from all that heavy lifting. My youngest patients are in their 30s. My oldest patients are in their late 90s, early 100s. So everyone now, sometimes surgery is the answer, but if surgery is not the answer, we have other non-surgical options that can help make people more comfortable.
What would you say to the person who's considering going into the medical field and considering urology or gynecology? What do you say to that student who's looking to find something that combines, like you did, their love of surgery and their love of the female reproductive system? What courses or things should you do in prep?
I think a commitment to making women's lives better is very important, and to be honest, is my favorite part of my job. I tell people I feel like I give them their lives back. They maybe have not been able to do things that they enjoy because they were worried about discomfort or leaking. So I think really just wanting to be a good person and do good things for people are key components. I think it's important to be good with your hands. It's important for medical school to do well with sciences and math and everything. But beyond that, I think it's a desire in the patients you touch to make things better for them. And my favorite part of what I do are my patients. I get to take care of mothers and grandmothers, and it's just a joy. And they are with me for years and years. And they have I have a rule in my office that you can come and cry about anything and everything. And we have an all-female office. I'm a female. My nurse practitioner is female. My support staff in my office are all female. And we tell people, people apologize for crying. And sometimes it's tears of joy. Sometimes they're upset. Sometimes they just need some attention and someone to listen to them. So we have all crying is totally fine rule, and no apologies for crying. They can cry about anything they want. And sometimes you just need a friend. Sometimes their husband passed away, a child passed away. But we try to take care of them emotionally as well as physically and medically.
Do you find in your experience and in your practice that there are a large number of people that come in simply to change themselves cosmetically without any problem whatsoever, without having a prolapse or without gravity taking over or without having had an injury? Do you involve yourself in strictly cosmetic surgery when it comes to urology or urogynecology?
No, I don't think that's the case. I think everybody I see, for 99.9% of them, have something that bothers them or irks them, and we can make that better. Or sometimes, on the rare occasion, it's for me to just tell them that that's totally normal, because we don't necessarily see other people's, pelvic areas. And I tell them that is a normal thing. You're not abnormal, and that in of itself is very reassuring. But in most of the cases, they do have something that pains them or bothers them as they're uncomfortable, that we can make better.
Right. Well, it's been great having you in with us today, Doctor.
Thank you very much for having me.
Thank you. Where can our listeners go and get more information about urogynecology?
They can go to our national society, which is www.augs.org.
Thank you. You've been listening to Health Professional Radio. I'm your host, Neal Howard, in studio with Dr. Tina Mahajan. She's the Division Chief of Female Pelvic Medicine and Reconstructive Surgery at University Hospitals in Cleveland, and she's been in studio with us talking about the field of urogynecology. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm, and you can subscribe to this podcast on iTunes.